lots of points in common, because some major issues in our profession, long waiting lists, lots of vacancies in the workforce, and good to hear people think along common lines. I think it's not very often that you have a discussion where the participants get to provide questions. So this is one of the first for me, and that was great to experience and see the range of questions. I think it might break down barriers. It gets people talking to each other as well and realizing we all have the same sort of challenges and barriers.
The debate, I enjoyed the debate this morning, and that is regarding the paper that's going to be submitted for parliamentary discussion and debate. It's nice to hear the questions that were asked from the delegates, and also how the panel answered these questions.
Interesting to discover and feel that there's a lot of common themes running in the private sector as much as the public sector. In other words, there's a lot of crossover there. So yeah, good event. Yeah, the audience did their bit. They were teed up and told to ask some questions, and our chair of the panel session did a sterling job pulling those questions together and making sure that we all gave a good account of ourselves. And I think we actually answered the questions into the bargain.
Very interesting, like the panel talking through the questions, and yeah, just found that all interesting. Yeah, no, I thought the talk about referrals, was interesting. I'm originally an optician, and I think the models there for improving the referral system within audiology, similar to what optometry has done over the last number of years, has come on where you can get referred directly. Something like that would be great, So it was interesting to hear the panel discuss that.
BSHAA is really a big part of the community. They're really driving forward audiology services, and I feel it was just an important decision for me to be a part of that, and to be here, to be part of the family. I just find it all inclusive, very informative, very passionate, loads of energy, and when it came down to the panel and the questions, and there's really everybody had that opportunity to have their say. It was fantastic.
It's been incredibly powerful and very moving as well.
I think it's the panel piece of the roadshow, really, from my perspective. I think to get that level of experience all on one stage, all at the same time, all with a common goal to move audiology forward across the UK and Ireland, I think it's probably a first, and I kind of felt like I had to be in the room for that. I think there's an awful lot of initiatives. I'm excited to see where some of the conversations will go with regards to them going to Westminster or Stormont, wherever else. I think they've got the flavour and the temperature of audiology across the UK and Ireland as it sits here today, right now, totally correct. I especially liked some of the conversations that the panel had around the future of audiology and where that needs to go and what we need to do today for the next 10 to 15 years.
Today, fantastic. So you can get a feel for what is going on now, and this is how you're going to get involved today. So a couple of months ago, we heard Jeremy Vine doing a fantastic article about hearing loss on his Radio 2 show, and we thought, wouldn't it be amazing to finish our finale roadshow with the most amazing journalist and panel host? So please, can you welcome to the stage Jeremy Vine, please?
Thanks, everybody.
Right over there.
This is not the smallest panel I've ever done, okay? And I'm aware we've got very high standards set in Belfast and Edinburgh with previous panels, and doubtless you've been to them. But what I'm going to do is, I think I'm going to introduce the panelists one at a time. And as I say who they are and what they do, you pretend to be incredibly surprised and welcome them one at a time. So the first one we're going to have on, I met him earlier, he's a lovely guy, Dr. Rakesh Chopra. Come on, Rakesh. And you've seen him already. So he is ENT, he's a GP. He is also, I asked them, give me one thing you do that's nothing to do with hearing or audiology. He said he's written books. Do sit down. He's written novels. What was the last one called?
The Mystic Typewriter.
You nearly forgot that, didn't you? Secondly, please welcome Dr. Krish as well. Again, ENT specialist, another GP. When I said to Krish, come on, give it to me, what do you do that's not audiology? Serious tennis player, almost professional. Yes?
Nearly.
Yeah, that's nearly and almost at the same thing, yeah. So, next we have Professor Kevin Munro, Professor of Audiology at Manchester University.
That's mine. Yeah.
Kevin gave us a number of possible other descriptions. I'm going with poet, and a serious one, has been published, okay? We need our poets. Now we are going to meet Gordon Harrison, audiologist with Specsavers. You know Gordon. He's been on these before. I hate to use the word failed, but Gordon said failed professional footballer, although played professionally for Falkirk. Yeah? It's a serious thing. Then Simon Lloyd, Professor of ENT in Manchester. Cochlear implants, his speciality. He can play Hotel California on the guitar. Now, this is exciting. Please welcome Karen Shepherd. Thank you. I'm loving these descriptions. So we've kept Specsavers and Boots apart, as you can see, but Karen is Director of Audiology at Boots Hearing Care and has just been in Murder on the Nile, the Agatha Christie, and she won't tell me whether she died at the end or not. She's just done a 4-day Amdram run, so well done. Now, next is Harjit Sandhu. Come on, Harjit. Association of Primary Care Audiology Providers. Describes himself as a foodie who runs. And then also we have, let us see, Ellie Cadman, come on in. What a panel. Independent audiologist. And she stopped the room earlier when we were having this discussion. She has been a judge in a contest to find the cutest rat. Correct? So if the whole discussion kind of fails, we will start talking about that instead. But what I must do, we've obviously seen that film where we saw the issues that have been raised in the Roadshow previously. And I wonder, Kevin, if you could just sum up where you've got to with all these discussions.
Yeah, thank you. So we've had a number of roadshows. I guess the context is people cherish the NHS, but recognise the NHS is now 75 and it's starting to creak a little bit. The context, I guess, has partly been shaped by a new and inexperienced government who have admitted that the NHS is sick, that there's a need for a long-term plan and that it can't all be solved by throwing money at the NHS. A lot of the panel discussion has looked at the inequalities that currently exist in the country. You might be able to get earwax removed, you might not. You might be able to see a GP, whatever. I suppose the take-home message is there's been a kind of collective will to try and find what is the medicine for audiology? How are we going to make it better?
Yeah. I was on Radio 2, we were doing something about earwax removal, and we got absolutely, the lines just melted because people were so angry their doctors weren't doing it free anymore. And I then, a week later, had to interview Keir Starmer. This is before the election. And I was really cross about it. So I just belted him with a question about earwax. And he was completely, he obviously didn't know the issue at all. He started laughing, you know. But I know how big it is. So look, before we get on, I've asked my friend Rakesh here to give us a little moment of mindfulness involving hearing. Can you do that?
Yes, I can. Thank you, Jeremy. Good morning, everybody. So before I do that very tiny exercise, let me throw this to a room full of audiologists. What is the purpose of hearing? Anybody?
Brilliant.
More than anything else, it is to deliver sound. And the key fact which I want to sort of, get across is the importance of sound. When there was nothing, there was sound. Sound is what permeates the universe. Everything in the universe is vibrating, and sound is basically vibration. And the ear developed, if we go back, the oldest fossil we have is what is called the oldest mammal, which is extinct now, called Harmidian. And that was in the Triassic age, which was before the Jurassic age. They found middle ear with two bones. And that time it was merely a flight and fright organ. It was meant for us to hear the dinosaur coming or the saber-tooth coming and running away. But we've evolved a long way from there when we developed speech and language, so on and so forth. But what is really key and which is coming more and more, and I think will come even more in years to come, is the importance of sound for our physical, mental, and emotional well-being. Now, we develop the hearing in stages, but approximately 23 weeks when we are in the mother's womb, that's our first auditory environment. And that's when we start hearing sounds. And now we know that the sounds you start hearing at that point shape as what we become as adults. In fact, Dr. Alfred Traumatis said that all our lives we seek the audition of the fetus. Okay. And that's how important sound is. So I think right from that moment till our last breath, the sound is so very important. So I'll take only 1 more minute to do this exercise. So please play along with me, including you, Jeremy.
I will.
So I'll demonstrate once, and then you can do it the second time around, okay? So all of you just relax, drop your shoulders, forget about everything for a minute, take a nice but deep, slow breath, and not yet, but then you can close your eyes, and I'll show you what to do, and then we'll do it the second time around. So a deep breath, relaxed, and then we'll all just do an as low frequency and as long a hum as we can. This is called the humming meditation or the bumblebee meditation. So I'll demonstrate once. So if all of you are ready, please join in. You can keep your hands palm facing upwards, either on your thighs or in your laps. Relax for a moment. Be very relaxed. A deep, relaxed breath. Ready? 1, 2, 3, in. Now, what was the purpose of this? Now, at the moment when all of you and all of us are here, our EEG activity from our brain is on beta waves, which is the alert, wave which we have when we're doing this. But even with one humming meditation, just with one you did, you were able to drop your brain frequency from beta waves to alpha waves. So that is how important, so simply, sound is. So chanting, of course, we can go there. Okay. That's all from me.
I feel terrible because I now need to talk about NHS digital transformation. And it's like all the relaxation will be wrecked as a result. And by the way, I wasn't sure what note. Did you hear my note that I did? Was it okay?
Perfect.
Because I can't sing. Because I was worried it was clashing with your note. Krish, right, tell me, this is important. We keep hearing about NHS digital transformation, and somebody rings my show and says they're still using fax machines in Walsall. What's going on?
Well, I think why we're here today as well, and thank you for BSHAA for putting it on, and very pleasure to be amongst this esteemed panel. I think the NHS, it's, as we all know, is extremely stretched, and there's not enough, by background I'm an ENT surgeon, but there's not enough ENT surgeons, not enough audiologists, and fundamentally it's access to care. And when we're looking at digital transformation, it feels like that is the way that we're going to be able to work as a workforce and collaborate together, but we have to do that digitally and innovate kind of within that. And one of the things that I'm extremely passionate about, I know everybody here on this panel, is how do we create these innovative pathways to make sure that patients get to the right specialist or individual at the right time. And I think that when you look at the state of the NHS now is the only way really we're going to be able to work as a kind of group together with audiology, ENT, and all those allied health professionals as well. And I think the state now is how do we drive innovation to kind of bring us together.
Okay, I'm going to sound like a Luddite here, but we've been hacked a couple of times in the NHS, probably by Russia. And I had a Radio 2 listener rang and said the only way to deal with this is to go back to using Post-it notes. Now, we don't think digital's a wrong turning, do we? Because in the end, all the best things in life, the lady who said relationships are not digital.
Well, I think with everything, you have to look forward and be digital. I think if we were going back...
Do we though? Is it not a liability?
Well, I think the NHS is, and having worked within the NHS, having also tried to deliver services within the NHS, they are really robust in making sure there's a framework to go through. So patient data is extremely important. And if you are delivering services within the NHS, they're going to go through every little part of the kind of framework that you need to be part of. And they have this DTAC framework, which makes sure that patients' information is kind of shared appropriately, anonymised, and I think there's security measures in place. But there's always going to be people who are going to try and...
Of course I've got a phone and I'm modern, but there's a worry, particularly among our older population, of course. Kevin, I guess this comes down to politicians, and I think you mentioned we got a somewhat inexperienced government. They are now up against it in a big way, because they've annoyed, well, the two groups you must never annoy, pensioners and farmers. Farmers have guns as well, so so we're going to see them get very defensive now. So how do you deal with the politics of this?
Well, I think first of all, we as a hearing community have to speak with one voice. And we're actually rather fragmented right now, so no one listens to us when the government are being bombarded about cancer and obesity and mental health. So we have to find a way of speaking clearly with a common message. And I think the common message isn't that we help people with hearing loss. The common message is that hearing better helps you to live better and probably also to think better. And if you put it in that context where hearing is needed for good communication, it's part of our social responsibility. Given that we're an aging population, we need healthy hearing for healthy aging. The government sits up and takes a notice of healthy aging because it's a time bomb. It's about to go off. And that, I think, is where we need to locate ourselves. And hearing is one part of remaining independent, relying less on social and health system. How we articulate that is something that we have to agree. These different groups need to come together so we're absolutely clear. What I think will not work is going to the government and saying, give us money. They've made it clear. I mean, recently, the Chancellor threw something like £22 billion into the NHS. Chances are that will slow down the decay. That's not going to change things back to how we want it to be. So we certainly have to be innovative, and we have to think of ways of harnessing aspects of technology and having, I think, a strong and a stable workforce.
All right, we've got Specsavers and Boots here. So my understanding is one of the most vexed areas for your roadshow is that if you go to the dentist and they see you've got cancer in your mouth, you get checked through the NHS system, and the same with a tumour in the retina. If someone comes into Specsavers and you see a health problem, you don't actually have the cabling to the NHS, do you?
No, we don't. And I think, I mean, it's not just an NHS, and I think it's right to bring this back to the individual with a hearing loss. The individual with a hearing loss has to be able to access the services efficiently as possible. And at the moment, we're not accessing services efficiently. We're not getting people to the right person with the right competence to be able to deal with them quickly. And I think that's what we're looking at. Is there a possibility of being able to have audiology as a primary care service in the way that optics would be able to do that, where you go along, you see the individual, and you can refer directly to the ENT surgeon, the audiology department, rather than back through a GP, because that's really inefficient from our patient. It's costly in how we do that. And actually we have a rising population, Jeremy, and we also have less people coming into the workforce. So this challenge that we have is only going to get worse. So we have to come together and find ways of being able to actually deliver that service.
Right, so Simon, you know all about cochlear implants, and we were talking to the brilliant Jodie earlier, who was amazing. Simon, if somebody turns out to need one, but they've gone into, let's say, Boots or Specsavers, how do you start that process, and what's wrong with it?
Yeah, I mean, I think we've got fantastic services in the community now, and we've got fantastic services in the NHS, but it's difficult to get that communication. There are certain situations where communication is very difficult, and I think hearing aids and cochlear implants and other types of auditory implants is where it's very difficult to communicate because the systems just don't allow it. You know, we've got fantastic digital systems, and you would think that would allow us to communicate easily, but we can't even communicate between NHS hospitals, let alone between the NHS sector and the private sector.
So if someone comes in and the brilliant audiologist at Specsavers or Boots, private, let's say, sees this person is young and they need a cochlear implant, they have to say, go to your GP and go through it all again.
Yeah, it depends on the circumstances. So there are some community providers in the private sector that have strong relationships with NHS hospitals, and they can make direct referrals. And that's how it should be. There should be a strong relationship between the two because it's
Can Boots do that, Karen?
So, if we see a referable condition, we would need to signpost back to a GP, but for cochlear implants, there's a different referral mechanism, and we have a relationship with a cochlear implant provider that can do the assessment. So, it's innovative ways of accessing support.
But your cochlear implant provider is not NHS? Are they?
No, typically speaking, cochlear implants will be provided through the NHS.
Yeah.
So we would refer into that service where they'll get assessed. It can be done privately, but for the majority of people that have cochlear implants, they will have it done through the NHS. But we're a gatekeeper to kind of signpost people. So if we realise that they've been optimally aided with their hearing aids, and yet we know that the criteria of cochlear implants is, that they meet that eligibility, it would be our duty of care to kind of signpost them to the right places to go and get assessed.
Right, and Harjit, does that work?
Sorry?
I'm just asking, Harjit, does that work?
Yeah, it works. I work across eye care and hearing care. In eye care, we're about 10 years ahead.
Wow.
It's just normalised that the optometrist will send you directly to eye hospital or refer directly. In audiology, we're catching up. Cochlear implants are a really good example. There's no reason to have extra barrier. GP colleagues are incredibly busy. They don't want to be an inbox. And we need to roll that out to more audiology services, really.
So is this to do with the fact that a lot of people access audiology privately to start with, but then they can't get into the state system?
Yes and no. There's a growing amount of NHS audiology services in England, at least, provided out of hospital, and they're at different levels of maturity. So where the commissioners have enabled it, it is possible to have those links with ENT. But in other areas, you do have to get referred via a GP. And we don't have an NHS, like a National Health Service. We have a local, broken down, fragmented service. And that's at the root of a lot of the challenges. So you'll hear a lot of variation today. You'll hear us all come up with solutions. But in reality, at the moment, it's very variable.
Okay, and you speak particularly for smaller providers, don't you?
I represent providers of all sizes.
Yeah.
And I think I want to build just on Kevin's point here. We have a habit in audiology of dividing things into lots and groups. Every provider of audiology, including Specsavers and Boots, in the nice possible way, is small. And I'll give you an example. The London hospitals, one London hospital, might be as big as Specsavers is globally in terms of revenue, right? So the NHS is a massively complex, big system. And actually, we are all relatively small. And to Kevin's point, unless we get together, we're going to remain small and forgotten. And the only reason that matters is if we're not speaking up for the people that we look after, nobody will. So,
well, that's so fascinating, because that's what this is about in a way. So it's really fascinating. Ellie, so tell us about you. You have how many branches?
3 branches in the Midlands.
So you see a lot of walk-in customers who've got a problem, and you start right at the beginning with them.
Yeah, and one of the things that talking here just sort of struck a nerve with me is we see people come in with sudden sensory neural hearing loss on occasion. So that's someone whose hearing has gone overnight, and luckily they can present on the day with us, whereas they might be struggling to get to the GP, or they might struggle to get to an audiology service. So we see them, and then we're a little bit stuck, because if it's a Saturday and we can't access anyone, we've had to send them to A&E. And I've had some rather rude phone calls then back from A&E saying, you shouldn't be sending them, but these people need treatment within really 24 hours. So we're doing the best that we can within the circumstances.
And what do you, sorry, now I'm fascinated, because this obviously is the broadcaster's most terrifying thing. When someone wakes up with no hearing, how do you treat it? Tell me what I should do. Do you just sort of bathe your ears in water, or what?
I mean, I like to see them to make sure it's not simply a wax blockage to start with.
Okay.
Test their hearing to see, is it a conductive hearing loss or a sensory neural? And it's the sensory neurals we're really concerned about, because they need medical treatment quite urgently, and which would be a steroid treatment usually. Either,
but why can't you do that in your audiology?
So I can't do that, yeah.
Well, you can't prescribe anything.
But, sorry, Jeremy, so this is a medical emergency if this happens.
Yeah.
And they need to see someone like Simon probably. So what would you do, Simon?
Yeah, I mean, it is a medical emergency, and this is one of the things that I've been singing about for years, is to make sure that general practice and other practitioners know that this is a medical emergency. You know, if you lost your sight in one eye, there is no question you would be at the doctor's immediately. But if you lose the hearing in one ear, you think, it's a bit of wax, you know, I'll just hang on a bit. But the reality is, and actually there's been a couple of really good publications in the last year or two, that if you treat sudden sensory neural hearing loss within the first 7 days of it happening, you can get a much better response to treatment. I'm not saying that the treatment is that effective, because it isn't that effective, but the mainstay of treatment is steroid. And the easiest way to get the steroid in is by mouth. There's a bit of an issue because the brain has a biological barrier to steroid, so not that much steroid gets into the ear if you take it by mouth. But The other way to give it is as an injection through the eardrum, so it's called intratympanic therapy, and you can give a combination of both the medication by mouth and the injections to maximise the amount of steroid that you get. But the key is to get into an ENT department.
This is fascinating. But obviously the solution to this is that you should be able to prescribe steroids, but that's never going to happen, right? Or is it?
Yeah, I mean, absolutely. So I have been teaching for years and years to all cadres of primary care that if you suspect a neural deafness, if you can't explain it by an external or middle ear cause, pick up the phone. I tell all audiologists, I tell all GPs, pick up the phone, talk to the hospital, talk to the ENT on call. And I say the same to audiologists, pick up the phone and speak to your GP if you don't have that direct access. And that's one of the problems which I think, which is there to come into the second point, is that GPs are inundated, Jeremy, They don't have time for hearing loss. Secondary care people, in most categories of hearing loss, again, don't have much time for it. Audiologists, GPs as such in examining the ear are pretty rubbish. So audiologists are very well placed between these two genres, and they are really ideally placed to take this on. And I hope that we can take audiologists, like you keep mentioning, to the level of an optician, where they should have direct access whenever they need to, and especially with sudden hearing loss, because the medical legal cases are rising exponentially.
Just to dwell on this for a minute, if I woke up and I couldn't see, I would not go to an optician. I would probably go to A&E. So what's interesting is if you can't hear, you go to an audiologist. If you can't see, you go to A&E. So we may go on.
Jim, I think what you would probably do is go to your GP in the first instance, but getting an appointment with the GP can take a little bit of time, and we need to act within that first 72 hours. I don't think the challenge is us knowing what to do. We know as clinicians what to do, who to refer to. The challenge is the referral routes and the ability for us to be able to see people front line and refer them into services to get the right service early. That's the challenge, and it's very much a postcode lottery, depending on where you are, whether that's cochlear implantation, onward referral, whether that's sudden sensory neural hearing loss. It's the fact of if you go to the GP should know what to do, but not all GPs go through ENT rotations.
Someone's brilliantly agreeing with every word. You're just saying yes the whole time. I'm loving it. Why do you feel so forcefully about this?
Because that is exactly true. And Rakesh is there saying about picking up the phone, which is absolutely the right thing to do.
Yeah.
But in the majority of cases, we cannot get through to anybody.
Okay.
You pick up the phone and they don't want to talk to you, or they refer you back to your GP. So you then go in an absolute big circle.
All right, I'm conscious because I sat at the back earlier that a lot of people won't have heard what you said, Jude, but thank you. It's all about this blockage in the system where there's no one to call. Now, I hate to say it, but because I present on Radio 2 every day, and my listeners ring every day, and whenever we do, how long did it take you to get an appointment with a GP? The answers are unbelievable. 3 weeks is fast in some areas. I got to a thing where I called my GP and they say, you can do it in 3 weeks and 1 day. So I said, okay, put me down for that. And they said, no, you'll have to ring tomorrow for that. Because they only open a 3-week window. So in the end, I came off the GP and I went onto something called GP at Hand, which is digital. So I'm trying to be modern about it. It's not ideal though, is it?
Well, I think it's about awareness. Because even as an example just now, you say, well, what would I do if I, couldn't hear? You would take that time, whereas for all of us here, and everyone in the audience, it is a medical emergency. And so I think as a collective group, there's one awareness kind of publicly so that people know what to do in these particular conditions, but also how do we as a collective group create those digital pathways that allow you, even if you went to GP at Hand, how do you get to an ENT as an emergency?
Karen, what do you think?
Well, I sit and listen, and we've gone down a little bit of a rabbit hole, because I think actually if we put together all of our years' experience here and out in the audience, what has not changed over all of these years is meeting the unmet demand. So we're talking about medicalised issues here, which is a very tiny majority of the cause of hearing loss. So the cause of hearing loss, very typically for our adults, is through the ageing process. And we've talked about healthy ageing, and we've talked about that social and the emotional well-being and the connection. So you ask about hearing, and for me that's connection. And if we don't have connection with people, so being able to keep people in the workplace longer, keeping their work life better, keeping their relationships healthy and better. So for us, here now, I think we don't want this division between services, between the NHS or between the private sector. What we want to be able to do is to say to the public, it's really important to get your hearing checked and be able to access a service in the easiest possible way. And given that the majority of those causes is non-medicalised, then we don't need the GP in that pathway. So how do we open up an innovative model that allows people to access audiology and improve their hearing, their relationships, all their well-being, healthy ageing, and how can we do that in the least resistant way? And Kevin's published a study recently that has increased the prevalence that we talk about now. So if we say it's 18 million people, and we only know that 2 million units typically get fitted, and I've been in this profession a long time, and that has not changed. So it's our duty here to explore how can we change that, how can we educate and open up the system.
But I'm just decoding this as the sort of the journalist here thinking you want the government to start putting money through the private audiology sector in order to bring in people who have that need, correct?
I think it's about being able to give people choice, and then, you know, being in a position, whether you're in the NHS or in the private, we all operate within the same regulatory frameworks, the same quality standards, the same referral criteria, so we can all agree that we can trust each other. So then it is, well, what is it that the government, if they would maintain free at the point of delivery, what is it that allows everybody to be able to give that as a choice to the public accessing the service from whomever that provider might be? And then what is the additional choices that a customer might want, patient might want to have if they don't want that solution but they want something else, or to build on that solution.
Go on, Kevin.
So the biggest risk factor to you, Jeremy, for a hearing loss is ageing, right?
Yes.
That's the biggest risk factor, and excessive noise exposure would be the other one.
Very good.
But we medicalise it, and this, I think, is part of the problem in this country, that we expect everyone to go to their GP and then be referred on. I'll give you just one example. So my elderly father, so for many years I was the only professor of audiology in the UK. My father would go to the high street to get his glasses, we'd go down to the high street for his feet, he'd go down to the high street for his teeth, and when I would say, Dad, you need to get your hearing tested, he would say, I'm not ill, there's all these poor people that need to see the GP, I'm not going to go down and join that queue. And then he'd say, but I'm not ill, I don't want to get referred onto the hospital. Now, I'm a professor of audiology, and I struggled for like 10, 15 years with my father. One of the problems we have is GPs have always been viewed as the gatekeeper into the NHS, but Rakesh will tell us GPs are under considerable strain right now, and if someone with a hearing loss goes to a GP, Rakesh will tell us, what can a GP do? Look in their ear, maybe be able to say if there's wax or not, and then send them on. If the GP was out of the equation, it would help demedicalise hearing loss. It would, I think, also help reduce the stigma. And people like my father could go somewhere where they could look at his eyes, his ears, his teeth, his feet, without having to come and clog up GP surgeries, Rakesh, don't you think?
Absolutely.
If everyone has the money to pay for it.
Well, a lot of hearing tests for the elderly now are freely available through Boots and Specsavers. You know, I think that the awareness, blindness is easy because you go blind, you go crazy, I'm blind. But deafness, because they are not aware that this could be a very, very serious problem, there's not so much awareness. Neither is there awareness of the importance of hearing. They just get on with it. So we really need to change that. And there's so many separate subgroups also that we need to address about hearing loss. The young people with their earbuds all the time, the noise exposure, the people in care homes. I really worry about the people in care homes because I feel they are really old, they're already isolated, they're already lonely. And if they don't get enough hearing, it's a downward spiral. I won't even go to the word dementia, but, you know, it's a big debate in itself. So I think there is so many aspects of hearing, all very poorly. The awareness is so poor.
All
it
right.
just needs to be.
But the classic here is you say, right, here it's three things on the high street. It's the optician, it's the dentist, and it's the audiologist.
And the pharmacist.
And the pharmacist as well. Okay. And that's great. It's great for Karen, it's great for Gordon. But it does cut people out, Gordon. That's the trouble, doesn't it? Because some people wouldn't be able to access that for whatever reason.
Because it's free at the point of contact. So NHS services, whether they're commissioned in a hospital or commissioned in a high street, that is already prepaid. So it's free at the point of contact, but what you are able to get is a set of specifications. You're able to get the audiologist involved to make sure that the right outcomes are there and the patient outcomes are there, and deal with those people that can be dealt with our competence that we have, and be able to then pass those on quickly and efficiently to the right people, to be, whether it be cochlear implantation or whatever else that we need for further investigation from there. So those people that attend High Street, we deliver 250,000 NHS patient pathways per year at this point from there. Now, if we weren't to do that tomorrow, the NHS would fall over quicker because they would not be able to deal with the demand from there. So we're not saying everything has to go through hospitals or everything has to go through the high street. We have to use what we have as a profession, the amount of audiologists that we have a profession, to meet the demand of a rising challenge. And that is there. And that's already being paid for, whether it goes through the high street or through the NHS. You will get free at the point of contact. You will get good patient outcomes, outcome-based measures that we're actually looking at to be able to drive services from there.
Is that right, Harjit? You agree with that?
I want to absolutely back what Karen and Kevin and Gordon have said. We're sort of trapped in history. I was 3 years old when the leading charity first called for this. Hearing loss is not an illness. We have to get out of hospital. And fundamentally it's a major inequality issue. Today, if you have the ability to pay, you have a primary care audiology service. And what we're calling for is an NHS primary care audiology service to tackle the very thing that you rightly challenged. How do we make services equitable to access for people based on clinical need? And we have it. We have that as fundamental NHS principle. And all we're calling for is that to happen in the NHS. And it doesn't. People with hearing loss are having to jump over many barriers to get care. Imagine a crazy world in which when you're 40 and you struggle to read, everyone says, don't worry about it, just push a bit further, and then you slowly give up reading because opticians are all based in hospital and you can only get spectacles from hospitals and hospitals are busy. It's literally the equivalent of what we have for adult hearing loss.
So where's your sort of point of entry for this person who's got, as Karen says, not an emergency, it's age-related, so it comes to us all, I guess. Where do they go? Who do they engage with first?
Right now, there are already NHS services in primary care settings, on the high street, in some regions in England where you don't need a GP referral. NHS patients can go straight in and have a free NHS-funded complete pathway for their adult hearing loss. That already exists. It's just not...
Ellie, what do you think?
Yeah. I think there are these barriers, definitely, and I spent a long time in the NHS as well, and yeah, it's trying to get the access for people locally is really important, because little old Doris doesn't want to wait an hour to try and park in a hospital car park that hasn't got any space for her for something that she doesn't really need to be in a hospital for. So if we can get the services locally, it just makes it much easier for people.
But taking it completely outside the NHS creates other problems, doesn't it?
Well, no, because there were, and there still are, plenty of NHS providers that have services in the smaller cottage hospitals or in other small settings, which were much easier to get to. And then there's been this, every 5 or 10 years, we bring the services back into the hospitals and we push them out again, and there's this constant to and froing of where we sit as audiology. We don't really fit within that hospital framework, though, and I think that's been evident of that to and froing over the years.
I'm just thinking, Simon, if you see, as a professor of ENT at Manchester, you see your local MP, he's receptive, he says, what can we do for you? We're a new government, we've still got stuff we can do. What do you say?
I think that relationship needs to strengthen it. You know, this has been a kind of organic process. You know, if we were starting a service nationally from scratch, we wouldn't have done it the way we've done it. And we're kind of fighting a battle to try and get that link set up correctly, which has never been there. And actually, I think if you look back to the philosophy of healthcare in the UK, it's all been NHS, NHS, NHS over the years, and the private sector's kind of been frowned upon by the NHS, and that's quite a hard barrier to get over, and I think we do need to get over that we've got to accept that healthcare has got to be a blended model, and we've got to use the expertise in the private sector and in the NHS and just find a way to link together much better than we currently do.
I just wonder whether dentistry is a warning for us, because we have now these things called dental deserts where people haven't got any access to any dentist. As a result, some people are, you know, doing the thing of tying a tooth to a piece of string and tying the other end to a door handle, and drinking whiskey and slamming the door, and it's not even, in fact, I think my colleague Steve Wright was doing that for a while. It's no joke, you know, and the government, when it came in, incredibly said, we will make sure everyone in the country has an NHS dentist. And I just think that's kind of impossible now. And so dentistry is the canary in the coal mine, isn't it? Maybe for the whole NHS.
Well, I think we should always look at other specialties. I think Harjit made a good point of how do they do it in the optical world? And actually, as a group, we probably are kind of behind the optical space. And I think if we look at how they deliver it, that could be something that we kind of model. And
so what's good about the optical world?
Well, I think that it's available. It's available in the community and access, and there's clear pathways as to how it works between the opticians and the ophthalmologists. And, you know, I think that's where we could kind of mimic. And Harjit, you've done a fair bit of work about that.
Yeah, I would say dentistry is the doomsday always, you know, what about that? Right now we have record low satisfaction with the NHS service. In primary eye care, your opticians, you have record satisfaction. It's timely access, we're picking up disease early, we're willing to do more. The evidence is there, our own regulator surveys the public, and you have 92% satisfaction. So there's also very positive stories about what the NHS can do in primary care. And just pick you up on it's really interesting ways for me listening to this. Sometimes the NHS sounds like a provider service, but it's a patient service. And we get so dragged into what's the category of the provider? You don't have that in Germany or France. If we think about patient service, patients honestly do not care when we survey them. What they want is NHS-funded care, convenient, safe, and often close to home. So we're fully behind the government's 3 big shifts.
So you wouldn't give the message, who's going to answer this, I wonder, that when you ask the NHS to do things, I'm sorry, they don't get done very well.
They rarely get done.
And you can do them better. You wouldn't want to say that. Kevin, nobody wants to say that.
Well, thank you. First of all, I just want to make it absolutely clear that if people want to pay for the healthcare, I have no problem with that. But I think the NHS should be there, including hearing services, free at the point of care for everyone. There's an opportunity that the provision of this free care could come from traditional NHS, or there could be other people out in the community or the high street who could help shoulder some of the workload. But what I'm interested in is maintaining it free at the point of delivery for people.
Isn't that the greatest failure of all, not to see beyond that promise, which just doesn't work anymore? It just isn't working now, and it won't ever work again, because we've got a tiny island with 69 million people, and most of us seem to be living to 84.
So, I mean, if you're saying a time will come and all our GDP will be spent on healthcare, you may well be right. But we're not there yet. And I think there are things that can be done for hearing healthcare right now. I think there is a great opportunity to move from the kind of the more analog to digital. We have hearing tests that people can do remotely at home. Yeah. They can, when the adverts come on for Coronation Street, they can turn it down and they can test their hearing. They could do that at home. There's blended opportunities where devices and support can be given to people for using at home. And if they need the support of professionals, then that's the time to get it. But we shouldn't be using, it comes down to the argument about machine learning and AI. Why would a health professional spend time doing something that a machine could do for them? The concern that people have, apart from can you trust it right now, or you're going to get rubbish if you look at GPT, the concern that people have is that they're going to lose their job if it goes down there. But actually what it will do is it will free up professionals to use their skills where they need them most. So there are definitely opportunities to be innovative with technology, as well as addressing the workforce issues. And if we were starting, I'm listening to Simon's point, with a clean blank sheet of paper, I think what we'd do is we'd find right now an area of the country where we know hearing services are particularly bad, where no one disputes it. And then we should sit down in a safe environment where we trust each other and say, if we could start from scratch in this area, how would we design it? And why don't we try it out? And why don't we then evaluate?
Should we do that? Let's just go. Let's start with Ellie. Right. One thing. So where are we? Blackpool. Let's think about where we are. Grimsby had So Grimsby this week was revealed as having more than 50% of adults of working age on welfare. So let's go to Grimsby. Ellie, what do you do? Just one thing.
So one thing for really starting from fresh. Is that what you're saying?
Yeah. So we're going to go somewhere, and we're going to use it as a pilot, and we're going to create a system which is actually going to be rolled out across the whole country, and the crowd here will talk about where they were today for years to come. Because this is where we decided how to change it.
No
okay?
pressure, Ellie.
So don't let me down here, Ellie. Come on. I know you drifted there a bit.
Let's just get rid of GP referrals.
No, that's fine.
Let's get GPs out of the equation initially.
I think we are going to take GP. We're taking A&E out for a start. Oh gosh, how interesting. Who claps? Are you a GP? No. Do you want to say why you clap before we get on with it?
I'm sorry to say.
We have a Radio 2 listener in the house.
You cannot die on a Friday.
Yeah. Listen,
Can I just
keep going. This is what do you, hang on a minute. What's your profession?
I'm an audiologist, married to an audiologist. My son-in-law's an audiologist.
That's like Basil Fawlty. So you're 3 audiologists.
Yes.
Right. So and which part of the country are you in?
Dorset.
Okay. We're not going to do, because I annoyed Karen by talking about sudden hearing loss because I became worried about it. But we're talking here about referring people to the GP. You don't like that?
No, because thank God, if there's an emergency, it doesn't happen very often.
Sure, I've understood that, yeah.
But I've always said, if anyone comes to us, I always question exactly why they want a hearing test. And if it's a medical emergency, I've always shoved them straight to A&E, and I said, just say, Mrs. Jones sent you, and I've already phoned straight through to the hospital for them. Blame me. Now, with a GP, it could take weeks to get an appointment if the patient doesn't know it's important. So Ellie's quite right, get rid of the GPs first.
Okay, right. So who wants to thank you? The case against involving the GPs in anything. Go on, Simon.
I certainly don't think the GP should play the primary role in being the referrer, but they ought to be involved in the process because patients will still go and see their GP with hearing loss, so you can't exclude them completely. We're kind of digressing a bit, but I think we need to basically...
We're not digressing. We're on Ellie, and we're going to sort Grimsby out, right? So we're absolutely not digressing. We had a little moment there. Ellie, what are you going to do for Grimsby?
Well, we'll have self-referral.
Self-referral?
Yeah.
You mean you think you've got some problem and you go somewhere?
Yeah.
Go on, Harjit.
It's going to be the same. Audiologist should be the first point of contact for ear and hearing care needs.
You're going to say the same thing?
Yeah, probably going to go around.
You're going to say the same thing?
Thing, I think.
Go on.
If we were starting again from scratch,
Yes.
then I would introduce that we screen people's hearing on a regular basis from a certain age. And that in itself will act as a triage and educate and inform. Because when we talk about wanting to maintain free at the point of delivery, if that's a viable option, we need to understand that treating hearing loss early and keeping people connected, informed, hearing well, not acquiring depression, social isolation, not at risk of fall, all those kind of things. What's the health benefit cost for intervening early? So if we introduce a screening program and then the audiologists are able to triage to integrated medical services.
Just so if you're over 50, would it be over 50 or when? A lot younger?
Well...
Go on, 40? 50 every 5 years? 15 years old and every 5 years. 40 every 2 years. Any advance on 40 every 2 years? You just bought something. Go on, Simon. Come on now. So, okay, these two have the same idea. Didn't help us here that much, but it's a great idea. You're the first. Everyone cheered, so that's good. Karen's is brilliant because I hadn't even thought of that I should be getting a letter every 5 years. You could write me when I go into Specsavers. You're my local people. You just say,
only if you do GDPR and allow us to do
I don't mind you saying, how about an ear test? Simon, what's your idea for Grimsby?
Just on the subject of screening, I mean, that is really important and it is something that we should be striving for. There are already national programs for things like flu vaccinations that pick up exactly the people that we should be doing hearing tests for. And there, as Kevin said, there are some fantastic apps now for doing hearing tests. I don't think it would be particularly expensive to tag on a hearing test every time somebody comes to have their flu jab, and that would identify an enormous a population of people that don't currently have that discussion about how to deal with their hearing aids. Anyway, that's a kind of side issue.
No, it's not. That's a really good idea. The idea that when you go in for one thing, you get a hearing test.
Yeah.
That's a brilliant idea.
Just to try and because obviously we're very cost aware these days.
Yeah.
We need to make sure the costs of whatever we introduce are cheap. And I think that would be the easiest way to cheaply introduce screening across the UK, just to tag it on. And that's
all right. We're still thinking of Kevin's brilliant pilot, Gordon.
So
Grimsby, the pilot Grimsby.
So the pilot Grimsby, the bit that moves on for me, you have the screening, you have the self-referral, then you've got to have the agreement of how you onward refer to the appropriate specialist to make sure that whether that's straight into ENT, straight into cochlear implantation services, or whether it's got into audiology service for additional tests at that point from there. So being able to agree that pathway and make sure that that sets up so that people get the service that they need, they're getting that initial assessment, they know where they are, and they're being put in the right place.
Forgive this naive question, but a lot of people need hearing instruments, and if you suddenly started testing everyone every 2 years over 40, you'd have a massive demand for them. Could the NHS deal with that, Kevin?
Hearing care is one of the cheapest parts of the NHS. If you go with a dodgy ear, whatever, you fall off your bike that you were telling me about earlier, you know, £350 to get a scan or whatever, people will get their hearing assessed and 2 hearing aids for £350. So actually, it's cost effective. I think in terms of screening, there's a study waiting to be done. The National Screening Committee have not supported adult hearing screening because they say we've not got the evidence. What we don't know yet is what age should you test someone's hearing at? What would be the intervention, and are they going to accept it, and how would you test their hearing? And it's a study that's, it wouldn't solve the Grimsby problem overnight, but it's crying out for someone to do an assessment and provide the evidence to say, this is how it could work within the UK. I think for the majority of people that go for a hearing test, it's not a medical issue. They don't need to get referred on for implants. It's not a profound or a sudden hearing loss. So we'd need to have red flags so we know how to deal with these people. But for the majority, it's not that at all. So it's once they get into a service, who's going to provide that service and look after them? And it's more than just providing hearing aids, I should say. If you get a hearing aid without good audiological support, you're likely to give up wearing your hearing aid. And they're finding that out in the States right now. They have over-the-counter hearing aids. Come to Costco and buy your hearing aid. And the return rate is something like 40% right now. And the evidence is the highest predictor of satisfaction is the quality of their interaction with your audiologist.
Yeah.
So that's key to what we're talking about here. But there needs to be a way of building trust. So it doesn't matter whether an audiologist is on the high street or in an NHS setting in a community or an NHS setting in a hospital. There has to be some element of trust, and everyone has to be working to the same standards and delivering the same outcome. So for my study, if we were to go to Grimsby, that's what I would want to implement, and then evaluate and say, is everyone working to the same standards, and are we all getting the same outcomes? And try to break down the sort of us and them barriers that exist.
I promise only 2 more questions on Grimsby, but I was just thinking, Krish, that we haven't mentioned prevention here, and one of you, maybe Krish, it was you who talked about young people and earbuds. Yeah. And, you know, we have all these people who were famous in the punk rock era, Eddie and the Hot Rods and all that, who've got horrible tinnitus and hearing problems because, of course, you didn't wear proper ear protectors if you're a punk rocker. So maybe we could do that in Grimsby. We could put what would you put on the poster?
Well, I think it's making sure that what we've talked about is education to everybody from the early ages to actually those that we think, oh, it's an aging problem. And I think, you know, in line with kind of what everyone said, it's actually a pathway and a new service that has collaboration. So you do need to have audiologists, and actually audiology-led, but you need the GP involved and you need the ENT involved. And I think in order to kind of access everybody, make it digital, because if you went in, Jeremy, and had a hearing check, let's say at year 1, everything's normal, but then you came back and had it in year 2 and we started to see a decline, that's an indicator for us that actually, Jeremy, we need to actually get you into a pathway sooner. And I think making this whole way digital, you know, photo documentation, a record that if it does end up with Simon, he can look through and say, this is what it looked like at this stage, and now it's changed. It helps with our processing as well.
Yeah, I'm feeling with my friend the GP here, you should, I know you'll want to respond.
Well, thank you very much for saying GPs are useless. I mean, I've been saying it myself in that context. I have a slightly different slant at Grimsby, if you don't mind. I think 40 onwards is very nice, Tasso, but very ambitious. In 2018, NICE came about with a guideline called Assessment of Hearing in Adults, you must have said. And it recommended that people with learning disability, people with mild cognitive or suspected cognitive decline should have a hearing test every 2 years, 2018. That still hasn't happened. If I was to start with Grimsby, I would start at the sharp end. I would target the elderly, the vulnerable, maybe the homeless, the young, and these people who have problems first. That would be one thing. Then secondly, which is something perhaps which is not in your purview, is that we have 42 PCNs, which are primary care networks. Out of them, 30 commission community audiology services, so 12 are totally out. And out of those 30, only 15 have partially commissioned community audiology. So I think the first thing we would do is commission community audiology. Takes the GPs out.
Is anyone, you want to come back, madam? Okay, go ahead. It's very entertaining so far.
Rakesh, do you remember earlier you would have given Ray a prescription? You told us we should have contacted you first. If every GP was like you, we would not have a problem.
Thank you. That's all I wanted you to say. Just exclude
me. I was going to say, look, here's just a little NHS story which happened to me yesterday, which shows the problem when you have massive healthcare. There's obviously a COVID vaccine rollout now for certain groups. I'm 59. They keep saying you are eligible. Go on the app and book yours. And now twice I've done it, and I've looked at the eligibility criteria. You know, have you got asthma? Are you over 65, etc. I haven't got any, so I'd say none of the above, and it says you're not eligible. And then a week later, I get another email saying you are eligible. Please go on the app. And so I do it again because I think, what am I doing wrong here? And then the third time, it says, because obviously they've had people complain to them, it says if you are not eligible, tick the box at the very bottom saying I am eligible. So, I am eligible for other reasons or whatever. So I put, and I'm 59, I don't have a problem. So I think, okay, well, I'll do it. I don't really want to get COVID. So I tick the I'm eligible box. And yesterday I go to Churchill's Pharmacy in Chiswick High Road, and the guy sits me down and he says, right, over 65? No. Asthma? No. And we go through the same. He says, I'm sorry, sir, you're not eligible. And I managed not to go the full sort of falling down moment, but I said, okay, here's what's happened, and he was lovely, and he just vaccinated me. But that's a classic example. I mean, we've all got an NHS story like that, haven't we, Karen? I'm sorry to say.
And I think that's where the lack of alignment comes, isn't it, really? So it's who sets some policies and guidelines, and then how it's implemented and integrated. And I think that this division and advice, we just need to agree. There's lots of amazing guidelines and principles and regulations. There's all sorts of stuff that are out there, but we work, as we said earlier on, in all these little fragmented pockets. So it's about, let's just go, here's a set of rules, let's all work together, let's deliver a seamless service, and everybody says the same story, and then you've got the backup provision and follow-up care, etc. So I think it's just getting that common understanding and the trust amongst us all that actually, ethically, all we're actually trying to do is help the public to live better, and that's what we're all about.
Ellie.
When Dr. Rakesh, when you were talking about the sort of dual sensory and the people that need the screening, when I was doing learning disability clinics in hospitals, that is the correct setting for that, for the more advanced testing, for being able to provide the visual reinforcement audiometry adapted for dementia patients, behavioural audiometry and everything that we would need to adapt and do, that we haven't really got the facilities to do out in community. Community's got its place for our, we don't like the word, but more routine patients, but we still need specialist services in many ways that are still hospital-based. So we do need that kind of dual commitment for everyone.
But we need to... No, you first.
I was going to say, I don't necessarily disagree, but I don't always think it's about the competence, and if it's not there, it's about how people access services. So you can build competence and you can build the ability to do that. It doesn't necessarily always need to be in the hospital. So you can take, any one of us can take our scope of practice, improve our scope of practice, develop and deliver a part or a portion of a service from there. So when we're looking at it, let's not kind of put ourselves in a box to say this has to be in the community and this has to be in hospital. It's the ability to how could we best do this is what we need to be taking into those discussions.
Kevin?
I was going to shift direction and say
Please.
we need to stop being reactive and being proactive. We need to get away from the treatment and think about the prevention. It's nowhere near as sexy. You don't get on the front page. You know, it's not like we spent millions of pounds on this gene therapy and we saved this one child's life. It's very hard to get a headline to say, oh, well, we might have saved someone from having a heart attack or whatever. But the emphasis clearly has to shift if we're going to have any chance of surviving to prevention and also early detection. So instead of thinking about we have to screen at age 50 or 55 or whatever, it would be great if people took an interest in their hearing from a very young age. It'd be great if your teenage daughter you were talking about, who's into music right now, really appreciated, actually, we don't know, but there is a danger if you have excessive exposure to loud sound, that's going to contribute to a hearing problem. And it might not trouble you now, but when you're older, it will, and it's not reversible. So finding a way for people to take an interest in their hearing, healthy hearing, throughout their life. We don't, like women in glasses, we don't wait till somebody asks us at age 50, please come and we'll test your eyes at 55. We're a bit more proactive about it. That, I think, is what we need to do. And there are opportunities right now with AirPods coming that people can use that can amplify sound, devices that will remove background noise. So instead of thinking a hearing aid is a crutch to someone who's got a hearing loss, wearing this device can give me super hearing. If I go into a really noisy place, I'm going to hear better if I wear this device. So I think there are opportunities right now to shift the focus, but it's hard work to try and get people interested in prevention. The government say they're interested in prevention, and if they're really able to get some traction there before we get to the stage that we're a sick country and a sick health service, that could make a difference. But that's not going to solve things immediately. It's not going to solve poor Grimsby's problems.
Yeah. This is not a joke. I said to my wife, look, she's 50. Sometimes I say things and you can't hear me. Why don't you just have a test? And she's come out absolutely 10 out of 10. So I can see, I now know what's going on. It's become a joke between us. But you know, that's her first time she's gone anywhere near an audiologist at 50.
Well, I wonder if they did the right test. Because I expect a problem is when there's background noise present. And I wonder if they ever tested her in the presence of background noise. The number one complaint that people say is, I have difficulty in background noise. And the number one thing that an audiologist does, takes you into a sound-treated booth, put headphones on, and listen to little whistles in a quiet environment. That's not where we have a problem, right?
That's so interesting. I want to just talk about earwax, which is important. And I've avoided earwax, but I know, but it is the Radio 2 obsession. I'm conscious we've got 30 minutes left. It is a brilliant discussion. And also, when we've had an earwax moment, I want to get questions from you. And, you know, as brilliant as your GP questions were, madam, we might even get questions from other people. I don't know. But if you've got another one to fire, go ahead, sir. Think up your question. But look, who's going to start on this GP business? Because my listeners have gone mad about it. That if you go to the GP now to get your earwax removed, and this is somebody who needs to go twice a year, they will say you've got to go privately. And you have to spend £80 a time? What? How much?
Yeah.
60 in Dorset.
It varies.
They can't all travel to Dorset, madam. So, go on.
Earwax is a huge issue. And interestingly, it's one of the things that's made us get up the agenda with ear and hearing care because people really care about earwax. It bothers them. So that's a positive. It costs, on average, £60 for removing earwax in 2 ears out of hospital. If you look at the NHS cost, it's about £130 plus to do it in a hospital. Wow. And what we think should happen again is, look, actually NICE recommends this. You shouldn't be doing all of this, complex ears. It should be a community primary care service. It's been saying that since 2018. We haven't done it. And the trigger for the shift was the pandemic, as well as a few other factors where GPs didn't have capacity, they started to refer. So the real issue again is not skills, capacity, it's just the funding model. If the funding follows the patient, it's cost effective to do this out of hospital and close to home. So, you know, the reason patients are upset, and rightly, is they don't even have the right to have that NHS service, and it's been decommissioned by stealth. And we need to have an honest conversation about what can the NHS afford, how will it provide this provision, especially to those without the ability to pay.
So what isn't the answer, Rakesh, I don't know, a token, when you go to your GP, she says, look, I'm sorry, we don't do this now, but we give you a voucher, you present it to Karen at Boots, you get it done there.
That is a possible solution, but yeah, this is a very important topic for me because I'm at the hot end of GP wax removal by various people. Jeremy, anybody who can now do nail varnish is removing wax. Every Tom, Dick, and Harry round the corner has got a wax removal service.
Yeah, okay, let's talk about this.
Okay.
Yeah. And because you don't have to be, you don't need a professional qualification?
You don't. It's terrible. I mean, I have trained a few ear wax removal nurses. I spent 3 months on each one of them, whereas people are doing a 2-hour course of some flimsy, non-existent, of any quality, and they're setting up a wax removal service, and they have no idea, because I'm sure that even Sandhu will agree that sometimes, even for a trained otologist, I was one, it's not easy because you have you can have deep posterior superior pockets where you have the facial nerve which is exposed and the inner middle ear bones exposed, and you could do a lot of damage. And yet these charlatans are doing it right, left, and center.
Is that right? I did not realize that. Is that right in your experience? Wow. Anyone got any knowledge of a nail bar in their area that's doing wax removal?
Has anyone not?
Has anyone? No, go on. Okay, this lady here. Well, you're Specsavers, madam, aren't you? So go on. We've got a microphone. Here we go. Tell us what's happening where you are.
So Yasmin Qureshi, MP, knows hairdressers in her constituency who are offering wax removal and have queues of people because the need is so high. I also know dog groomers who are doing wax removal for the same reason. So anybody can set up and deliver wax removal without any kind of official qualification because it's not regulated.
Jeremy, do we need to regulate it? Okay, right. I don't want to argue with you, but we've got a lot of regulations in this country. Yes.
So the build on that is when we talk about accessing an audiologist earlier and being able to have an assessment if you've got earwax, if that money is as we were saying earlier on, follows the patient, you can get commission services. Commission services, therefore, have a specification. They have the ability to say you have to have this qualification to this level and whatever from there. People still get that access free at the point of contact, which is the right thing. People may have exemptions or may not have exemptions, but ultimately we are able to, through a commissioning service and through that self-referral and being able to say that you will be paid by an NHS or you will be paid by the individual, we're able to actually put a lot of regulation in place that actually stops people who are opening up dog groomers, nail files.
I mean, I'm amazed. Presumably, we are not far away from the Mail Online story about the person who's had their earwax removed by a dog groomer and has gone deaf as a result, or been punctured or whatever. Anyone else with an earwax removal story in their area they'd like to share with the room? Because there was quite a burst of outrage there that amazed me, and I wasn't aware of it. Oh yes, down the front. So sorry. Yeah. Sorry, this gentleman here. Are you Specsavers as well?
Oh no, I'm a private audiologist in Northern Ireland. So I'm also a board member of BSHAA. So my stories are very simple. There is a lot of people starting up north, and I see day after day people coming into my practice where they've been to these people and they had problems. The best one was last week somebody came to me and she said, I've been there, and she tried and tried and tried, and I went back. 8 times she went back for that person to try to remove the wax. She came to me, she sat down, I saw what she's done. Thank God she didn't do any damage. 5 minutes later, she was clear of wax.
Right.
And that's the difference.
8 times, okay,
These people, they are going on to so-called courses, and then they're issued with a paper that says earwax removal specialist, and they get out there and they do more damage than anything else.
It's crazy. Should the GPs... you've got a great idea, Gordon, which is to say you let the money follow the patient. If it's not a GP, do it somewhere else. It's just like we're not anywhere near doing that, are we? That's the trouble, Karen, isn't it?
I think that all that needs to happen is that the courses for training just need to be regulated and standardised, and then there just needs to be, repeat validation, because it's an ongoing process and skills need to be maintained. So if you work in isolation and that's just your one singular activity and you're not in a team or whatever, it becomes open for error. But where you've done a course and then those course providers have a mandate to say we revalidate your skills, we run continual professional development. So it's just making that community of providers. And then, as I say, it's exactly the same conversation. It's just education and awareness of where you could then go and what it is that you should ask for to see that you are a safe practitioner and that you can be safe and effective.
Krish. And I think it's the point Karen made there. It's really important for the revalidation to make sure that you are working within your scope of practice. And I think the course providers need to make sure there is a certain level of individual who goes through. They have robust training that ends up happening on a kind of annual basis so that we are seeing that actually this person, I mean, Simon and I would have done it when you're doing surgery, you have to do a certain number of cases per year and be appraised to make sure that actually you're still safe to do that. And I think that is where it needs to go, that there is a body of work that's happening, and even ourselves working with NHS England, making sure the right individuals are trained, there's a clear pathway for referral, and making sure that revalidation takes place. I think if you have those things underpinning, it allows then audiology to be put forward. And I think Harjit made a great point. This debate has allowed audiology to get up onto the actually mandate and actually be spoken about at NHS England. Otherwise, we may have been left behind as a group.
Gordon.
I'm just going to respond to your point when you said that we're nowhere near that. Actually, again, you're back in the postcode lottery because certain parts of the country commission earwax services already. So it's happening in some places, and some people are getting that great service and other people aren't. And we've got to call that out somehow to be able to say, actually, this is a big challenge, these are the dangers, and this is the solution for it. We can't keep going and asking for more money, but what we have to be doing is going with solutions, working together to provide those solutions, and I think these debates are great for that.
Yeah, no, I've learned so much here. Right, let's have some questions. Yes, sir. Oh, this is the Dorset posse.
There's one question there.
Oh, hang on, okay. We've got one over here. Can we just do one over here before we go back to Dorset? Madam, in the front.
Hello. I just wanted to sort of add on to the earwax removal because so I run 2 branches and we exclusively focus on earwax removal. The staff that I employ and train, we make sure they have at least 3 months training before they do earwax removal. But I do think that with the courses, because even if you try and say that, okay, the course has certain requirements for who they take on to do the course, there's still the sort of aftermath of, you know, that person needs to have maybe some supervision for like quite a few months after they've got their certificate. And there's no one really like sort of enforcing that. Like the fact that I do that with my staff, that's a choice that I've made. There's not really anybody kind of saying that that's something I must do. But for
And
me,
are you audiology or are you just earwax removal and nothing else?
yeah, so I'm an audiologist, but the service is just earwax removal. And the reason that is because where I started my clinic in Croydon, the demand is just extreme, like it's very extreme. So even when you kind of hear about all these hairdressers and things like that, the general public are not even necessarily going to be, they're going to be happy at the idea because there's so much demand for earwax removal that some people will just go to anybody. Like there was a physiotherapist that was doing earwax removal and I think there was a private audiologist that couldn't do earwax removal. I think it was Boots that was sending people to that physiotherapist because she was desperate. And then when we opened, that was in Bromley because we started a branch in Bromley, but when we opened, she was just like, oh my God, thank God that there's an audiologist that I can send people to. But there's so much demand I used to work as an audiologist in the NHS, and the reason that I started the service is because people were on the NHS waiting list for microsuction. We were one of the, in Imperial College NHS, one of the only NHS trusts at the time that was doing microsuction for NHS.
And what was the waiting list length?
It was months. So the reason I started my service is because people were on the waiting list. They couldn't have a hearing test because their ears were blocked with wax, and they were on the waiting list for microsuction, and they were like, if I give you some money, can you just do it for me?
Okay,
So
all
I used to go
right.
to
That's very
people's
interesting. Yeah, thank you. That's
Yeah.
amazing.
But I did just want to add.
Go quickly, yeah.
That for services like mine that we just do, I don't think that moving things to primary care exclusively is necessarily the answer, because even if you do that, there's always going to be some people that just want maybe a faster service. We specialize in same-day earwax removal, so there's a lot of people who they couldn't get an appointment at Specsavers and come to us. I think you were saying that like Specsavers is small. You know, what about a service like mine that's tiny? There's still a purpose that we have, even though we're paid. If you move everything to primary care, there's still going to be a gap for people that want a same-day service.
Rakesh wants to come in.
I have one concern. Who provides the training? You know, you have to be very clear as who is capable and adequately trained to provide the training. Who guards the guards? I'm very interested in that. Anybody and everybody is not qualified to train somebody else to remove earwax. Earwax removal, as I said in previous roadshows, is not a joke. So it has to be taken seriously.
So I'm part of a national oral group that are looking specifically at the training standards, but I just wanted to put a slightly different slant on it. The demand for these services wouldn't be so high if there were approved methods of self-management of earwax. Now, currently in this country, NICE you can go online, you'll find all sorts of gadgets for putting down your earrings. NICE doesn't recommend any of them. But there's a great opportunity there for research to explore that further. In some countries, they do recommend it. Actually, I was looking on the website for healthcare in Canada. The advice that you get in Canada, if you've got earwax, is to stand in the shower and let the water run into your ear.
Really?
That comes from the government in Canada. But there are European countries that have approved self-management methods, started with drops to soften the wax, and then bulb syringes to try and flush it out. And there have been 1 or 2 studies done in this country saying, actually in about 50% of the cases, it seems to work. But because none are approved, they can do that.
I'm still amazed by your Costco story about getting hearing aids over the counter. That's just blown my mind. Right, okay, Dorset.
Back to wax, we had 3 providers up there. We got TympaHealth, Specsavers and Boots. I'm assuming that for where you provide wax, and I'm new to the industry, although I'm second generation, I'm assuming that you have your training, validation and care pathways in place. There are 3 big providers there, so surely half the blueprint, half the guidance on wax is there. So can't we take you 3 together, put everything you've got on wax and how you keep your people trained and updated on wax, present it to a wax body, and the job's pretty much half done. So what do you do to ensure that your wax people, that's to Karen, Gordon, and Krish, what do you do to maintain that they're on their best game, and how do you recruit them and develop them?
Okay, so you're talking about having a wax body that would receive advice from our 3 wise persons. And are you happy with, basically, you're going to have to train people and make sure no one slips through the net?
Well, I think it's like Kevin's point, and I think certainly you're right. There is a standard of what you need to have, and what we did in our organisation was mimic it to kind of what I did in surgical training, make sure that there's the theory, make sure there's a in-person, make sure there's follow-up, but then make sure there's that revalidation, and everything needs to be digitally recorded. And also in the background, and to do with innovation and technology, there is machine learning working in the background. So if there's trauma, we are able to identify that those patients or those individuals using that, if they are high trauma, they need to get extra training. And I think some of that stuff, which I think needs to go into some of those frameworks, and making sure that people work within the correct scope of practice. And clearly, the other part is make sure there is a clear onward referral pathway, because for me, the patient needs to get to an audiologist when required, or to an ENT when required, or just get the right safe practice. And I think to your point is make sure it's delivered within the community and the patient has choice whether they want to go private or within an NHS service as well.
So, thank you. I'm conscious with 15 minutes left, we mustn't just do another 15 minutes on wax. Okay, so back to our big topic here, which is how this very interesting disparate group of brilliant audiologists and the great sort of blob of the NHS and how they work together. Yes, sir, over there.
Hi, Jeremy. Great to see you today. Much appreciated. I suppose I'm a bit the unicorn in the room. I'm an independent private audiologist and I have an AQP contract. So if you want to see me same day down in Tavistock, bizarrely in Devon, it happens already. I take self-referral from the patient they walk into my practice. Kevin, I agree with everything you've said. We've got to start working together, and this whole professional, the bodies are not. People aren't aware, one or two people know me very well. We've had this in place for 15 years, Jeremy. 15 years. Any qualifying provider. Gordon, you fully understand being with Specsavers. Karen, to put you on the spot, why hasn't Boots in 15 years gone down this process? Okay.
Gordon,
so
let's ask
the
Gordon.
Grimsby model is, as of today, from the 1st of May this year, you can come into my practice. I have an AQP contract. I can do self-referral. There's no requirement per se to go back to the GP. We take the GP out of the equation, which is fantastic. I do concur the referral pathway to my local ENT or audiology service is non-existent. They haven't put that back in place. I am in the real world when it comes to wax. You know, we were assured 10 years ago that the regulations would not allow unqualified people to do it. I don't fully understand how that's happened. And a little fly in the ointment, because a very good friend of mine sat behind me. How can a nurse of 30 years not be covered in the private sense? And I believe the fly in the ointment is, in a day job as a qualified nurse with the RCN registered, once that registration elapses, because she's now coming to the private side and is fully qualified, there is no mechanism to keep
All right.
her. So a couple of things.
I'm gonna, no, hang on. It was too much there. And you, in the middle, you said, you asked Gordon something that was really pointed, and I lost it. Boots isn't doing what you do in Tavistock, is that right?
Boots isn't, as far as I'm aware, Boots has not got an AQP contract anywhere in the country.
Okay, let's let Gordon answer that.
So the mission at Specsavers is to change more life through better sight and hearing, and that is why we run both private and public services, so AQP services, to give people the access to that. Again, like Kevin, we agree that people should have the option of having free at the point of contact, and we are happy to deliver those services, but we're also happy to say, do you know what, there may be other technology out there. We will apply and try to work for every one of those contracts that come out with the ICBs to make sure that people get that service, and we're able to provide a wider service in conjunction with the NHS services, not as a replacement, but in conjunction with those NHS services, so that people can access, because I think we've already said earlier on, the actual penetration rate that we have in this country is pretty poor, and Karen made a really good point on that, is the fact of how many people have we actually changed out of 21 million people who have hearing loss, and we're seeing 2 million a year. There's real discrepancy there. We want to sort of break that barrier down, but we're not alone. This is where we want to be stimulating. This is why the report came out, of how can we as audiologists work together so that more people like yourself in private sector can also be able to provide those services at a standard with right patient outcomes, free at the point of contact, and also have the ability to provide those private services. So it's a real passion of ours to, and this is why we brought the report out.
I'm conscious the question was to Gordon, but it was about Boots. So would you echo what Gordon just said?
I would, and the history really of involvement, and this is, you know, when digital hearing aids were first introduced into the NHS, the demand for hearing aids went up, but the capacity, the workforce capacity wasn't there to meet it. So R&ID were given some ring-fenced funding to explore, could the private sector provide an NHS experience? And that was proven, and we were part of that founding public-private partnership trial with another national company, Amplifon at the time. And then that was the predecessor for the Any Qualified Provider contract. And we carried on to do that work. But where it falls down is that under the Any Qualified Provider contract, it isn't a national framework in respect of each of the ICBs will negotiate their own service specification, their own journey, their own costs, etc. And you are not given a guaranteed direction of people coming to you. So to set up services that we feel we can do end-to-end, the right level of care and the right level of rehabilitative support meant that actually we got to a point where it wasn't sustainable and viable. And I think that that essentially is almost the NHS conundrum about the sustainability, viability and quality of care that's being given. So I think that this is what this debate is all about, is what should that service that's free at the point of delivery actually look like, and how do people access it, and how do you maintain the consistent quality wherever you live in the country, whichever home nation.
Thank you, Karen. So another question. Now we've got loads.
Could I respond, Jeremy?
Yeah. Well, no, so, well, quickly, yeah.
Okay, well, Karen, the AQP contract is a national framework. There's no if, buts or maybes. There is a national framework for it. You're perfectly able to apply for that. You're talking about cost variations. They're fairly minor between each region. I'm sure Gordon would agree. Gordon, with Specsavers, what's stopping you from having a contract in every single county in this country? You know, you could have a far more experience than myself. Devon and Cornwall is amazing. But what's stopping you as a company being in place?
It's legislation, it's ICBs being able to put the contracts out there and actually say, we will commission that service. From there, when they do commission a service, we engage. And we try to push that, and we've spent time at Parliament recently, and Parliament in Scotland recently, and at political party conferences to push that message, the fact that there is a postcode lottery. If you live here, you can get AQP services free at the point of contact in multiple locations, not just ourselves, Scrivens and other providers will do that. But in other areas of the country, that's just not there. But that is dependent on where the ICB choose to spend that money. And we are looking to try to get that commission everywhere.
The postcode lottery thing is difficult because Labour have come in promising local people will have power over their own community. And what you get from that is a postcode lottery. So it may be a good thing, because it may be that Devon does Alzheimer's really well and Blackpool does bad backs, you know, and maybe that's right. I always think postcode lottery is so loaded, it's kind of, a lot of politicians want it. Who wants to come in? This is fantastic. We've only got 6 minutes. Why don't we take like 3 quick points? Yes, sir.
Thank you. Yeah, it's been a fascinating discussion so far. Thank you to you all. I think the T word has only come up once so far. Given that 1 in 7 adults live with tinnitus, sometimes with significant hearing loss, but quite often without any associated hearing loss. Aside from preventative measures, what are the panel's thoughts on how the treatment pathway for tinnitus should evolve?
All right, I'm going to note tinnitus. Next question. Anyone else got something here before we close? Got someone down the front here. Yes, hello.
Hi,
it's all from this side of the room. It's so strange. Yeah.
Hi. I think going back to Grimsby, if we were starting fresh, I think that we should ask the Department of Education to put hearing health programmes in the syllabus. That's the first thing to increase awareness of how important our hearing is. And I'd also like to ask the panel, considering what our Prime Minister said about focusing on prevention and illness, how could preventative audiology be implemented in their practices?
Okay, thank you. Very good. Yes, this is good. Let's keep going.
Hi, thank you. We've talked a lot about the potential for standardising training for earwax removal in a really positive way. It's been very interesting, but I wondered what the panel members thought about standardising education around onward referrals more generally, speaking with a British Cochlear Implant Group trustees hat on and for the Cochlear Implant Champions. Specsavers kindly let me do a training webinar earlier this year to raise awareness about NHS referrals, but it seems to me that across the NHS and private sector there are challenges regarding mandating and ensuring people are up to date with their knowledge of who to refer into more specialist services.
I've got it, thank you. Just one more, I think, from the front.
Yeah, I'm a hearing care professional living with severe to profound deafness. I do have a point that I just wanted to pick up on that Professor Munro made earlier in the discussion. But before I do that, I just want to say thank you and acknowledge the sheer passion, dedication, and the discussions that we've had from the room today. Because if I hadn't had the support that I've had in my life since the age of 8 from the hearing care professionals, whether it's assessment, rehabilitation, batteries, tubing, moulds, upgrade to digital technology, I don't really know where I would have been. So it's just to say thank you.
Oh, let's give that. That's the most. I should have lined you up as the very last contribution because that's such a beautiful note to end on. Okay.
So the comment that I wanted to make
Yeah.
was earlier in the discussion, Professor Munro was alluding to the fact that it seems to be difficult to make the government recognise hearing loss on a par with other long-term chronic or acute conditions. And I'm surprised and disappointed that that's still the case, but I wonder whether there is scope for us to include lived experience, testimonials of lived experience, as part of our lobbying of the government.
All right, that's a brilliant point. Thank you. Now, because we've got 2 minutes and I'm determined to end on time, there are 4 things there. What's your name, by the way? Lena. It's a fantastic question. So Lena's testimonial should be on the screen next time we all meet. There's the first thing. How about that? Thank you. So quickly, each of you on one thing. Tinnitus is a massive... Ellie, you're the one on this.
Well, I have tinnitus
Do you?
and have done since birth, so I'm least empathetic sometimes because of that. But I think hearing therapists are well placed to help with tinnitus. We can give a certain level of support, and by getting hearing aids onto patients, a lot of the time that's going to help with their tinnitus.
Okay. The next one was getting hearing awareness on the syllabus, Simon. What do you think of that, the school pupils?
Yeah, I think any kind of education at that level is really important.
Teachers go mad because every time there's any discussion on anything, someone says, it needs to be on the syllabus, and everyone says, oh, yes, it does. And the teachers say, how many things are on the syllabus now? Martin Lewis wants us to have how to run a bank account. So, yeah, okay, let's give them hearing awareness.
Yeah, I think it's absolutely...
No teachers in the room?
Yeah, I certainly would encourage that. I mean, they get sex education. Why shouldn't they get hearing education?
Brilliant. Love it. Okay, thank you. And we're back with earwax removal over here and kind of the referral pathway. Rakesh, I'll ask you about that. So I think it's, again, at the heart of what we're discussing is how private audiology can actually see a way into the NHS. And it's just so complicated that we're now getting a call for people to be trained.
Oh, absolutely. I mean, I'm all for earwax removal out in the community and easy accessibility, but I have seen and see it on a daily basis on the ENT clinics I do that it is being abused, there is improper training, there is total lack of regulation. So I hope that that needs to be really taken, and as soon as possible, some standards and regulations be put into place.
Okay, Kevin, we'll finish with you where we started. Has this been the best panel so far?
Absolutely. the chair is the best, apart from the person that chaired the Edinburgh panel.
Oh, he was
Please thank our panel, everyone. Aren't they brilliant? So Ellie and Harjit and Karen and Simon and Gordon and Professor and Krish and Rakesh and me. And thank you. You were a most amazing audience. Thank you for paying such close attention. I hope that took the debate on. And thanks as well to our fantastic hosts here, BSHAA, I'm now calling them after somebody in the audience said that. Thank you so much. Thanks to the producers. Have a great lunch break. Cheers.